And the topic for discussion now is infectious mononucleosis. As we all know, infectious mononucleosis is commonly caused by Epstein-Barr virus, also called as EBV. Infectious mononucleosis is a condition most commonly seen in children and especially in the developing countries. It is also called as glandular fever or kissing disease. It is called glandular fever because they have a characteristic Epstein-Barr virus induced infectious mononucleosis has a characteristic condition like there will be non-tender enlargement of the lymph nodes, hence it is called as glandular fever. It is also called as kissing disease because especially seen in children, younger infants or toddlers and children, where it is usually the infection is passed from the oral cavity of one person to another person while kissing, hence it is called as kissing disease. It is characterized by pharyngitis, that is nothing but inflammation of the pharynx, and severe conditions there can be quinsy also, that is peritonsillar abscess also can be seen in these cases. There will be cervical lymphadenopathy, fever, and also lymphocytosis is one of the common feature in case of Epstein-Barr virus induced infectious mononucleosis. Now coming to the causative organism, most common cause is Epstein-Barr virus. However, certain other organisms also cause similar kind of condition like pharyngitis, lymphadenopathy and fever. Similar conditions constituting of all these three components in them, and those organisms include cytomegalovirus, human herpes 6 and 7, HIV virus especially type 1, and toxoplasmosis. Even these four organisms also will induce a condition which is similar to infectious mononucleosis. Now coming to Epstein-Barr virus, which is the commonest causative organism of infectious mononucleosis. It comes under the family of gamma herpes virus, and in children it is usually a subclinical infection, but this is the most common kind of condition that is seen, and it is usually infected by droplet, that is by the saliva contamination, that is nothing but droplet infection, and it is also by kissing one person to another person, and also it is not a highly contagious disease. However, in severe cases there might isolation may be required because even while coughing also these droplets can transfer from one person to another person, thus causing infectious mononucleosis in the other person also. Now coming to the structure of this virus. Normally this Epstein-Barr virus has an envelope which also has extruding out proteins called envelope proteins, and it has a viral genome surrounded by a nucleocapsid and also a viral tegument surrounding this viral genome. Envelope proteins and viral genomes are known to be the causative antigens, like these are nothing but the Epstein-Barr antigens. Coming to the clinical features, it has a long incubation period. Normally it also has some prodromal symptoms, that is fever, headache, malaise, and other conditions, other prodromal symptoms can also be seen in this condition. It is usually followed by severe pharyngitis. After fever, normally these patients will have severe pharyngitis with a tonsillar exudate, that is there will be pus discharge from the tonsils. However, the lymphadenopathy is seen, but it is a non-tender lymphadenopathy, especially in the anterior and posterior cervical lymphadenopathy can be seen. The pathogenesis, how this actual pathogenesis occurs is, while after a droplet infection, the primary infection occurs where this virus attacks the epithelial cells. Once this virus enters from the epithelial cells into B cells, that is the viral entry and replication will happen there, where it will promote the growth and transformation of B lymphocyte. Now this B lymphocyte with this infectious material will be a blasting B cell. This blasting B cell can undergo a phase of latency which later can reactivate. Once this reactivation occurs, this B cell will release these viruses which will enter into the epithelial cells again, and where the persistent infection can happen there. Sometimes what happens after the reactivation, these B lymphocytes with viruses, with the viral material components present within will undergo lysis. This lysed material will again enter into B lymphocytes, and this cycle continues. And this is how the pathogenesis of Epstein-Barr virus induced infectious mononucleosis occur. Once these viruses re-enter into the epithelial cells, there will be a persistent infection present there. And this is a picture showing tonsillitis, severe tonsillitis, and pharyngitis also there. We can see exudate coming from the tonsillar region. Normally, other clinical symptoms that can be seen are petechiae. Usually the palatal petechiae can be seen, and macular and petechial or erythematous rashes can also be seen, which will be similar to erythema multiforme type of rashes. And other symptoms includes periorbital edema. Around the eye, patients will have edema, and axillary and inguinal lymphadenopathy can also be seen associated with splenomegaly. Mostly what happens is within 2 weeks of time, these conditions will resolve. However, post resolution of the disease, fatigue and other symptoms also can persist for few more weeks. The main symptoms of infectious mononucleosis system-wise include: one is the central system, that is central nervous system. When it is involved, patients will have fatigue, malaise, loss of appetite and also headache. In the throat, normally because of pharyngitis, there will be soreness and also erythema of the mucosa there, that is nothing but the reddening of mucosal structures there. Respiratory conditions, cough can be seen. Cough patients are usually present with cough, and other symptoms include severe chills, fever, aches, body aches can be seen, that is nothing but myalgia. Patients usually have photophobia, that is they cannot see sunlight directly. They try to be in a darker place or use sunglasses, etc. However, they are not very comfortable seeing in the bright light. Next, tonsils are usually reddened. There will be swelling and white patches, that is the pseudomembranous patches can be seen over the tonsils. That is nothing but the exudate material and the debris which is usually present on this tonsils. Next, lymph nodes also show swelling, but the pathognomic feature is their non-tender lymphadenopathy can be seen in case of infectious mononucleosis. And the spleen undergoes enlargement, that is nothing but splenomegaly, and patients also will have abdominal pain because this splenomegaly will lead to distension of the abdomen, thus resulting in pain. And gastric symptoms include nausea and vomitings. Coming to complications of Epstein-Barr virus infection, that is apart from the clinical symptoms, if this Epstein-Barr virus infection, that is infectious mononucleosis, is so severe and is not treated in time, then there are some complications of this infections, which include the most common complications include severe pharyngeal edema. When there is severe pharyngeal edema, patient will have difficulty in breathing because the airway is obstructed there, and this can be a severe complication. Next, patients will also have an antibody-induced rash. Epstein-Barr virus infections are usually treated with antimicrobial therapy, that is antibiotics, especially ampicillin is given. This ampicillin can induce certain rashes on the body, that is nothing but antibody-induced rashes can be seen, is one of the complications of Epstein-Barr virus infection. Next, patients will also have hepatitis and jaundice. Coming to neurological complications, neurological complications can include several cranial nerve palsies. They'll also be having polyneuritis, transverse myelitis and also meningoencephalitis. These are also various neurological features that can be neurological complications associated with infectious mononucleosis. And other hematological complications include thrombocytopenia and also hemolytic anemias. And cardiac complications include myocarditis, pericarditis, and certain ECG abnormalities can be detected. Interstitial nephritis, abnormal finding on renal analysis, urine analysis can also be seen as renal complications. Certain rare complications are associated with infectious mononucleosis, and they include X-linked lymphoproliferative syndrome, agranulocytosis, they have respiratory obstruction, and ruptured spleen can also be seen in these cases. Coming to Epstein-Barr virus associated malignancy. Epstein-Barr virus is known to have, it is one of an oncovirus, that is it has high propensity to cause malignancies. And some of the common malignancies that are associated with Epstein-Barr virus include nasopharyngeal carcinomas and Burkitt's lymphoma, Hodgkin's lymphoma, primary CNS lymphomas and lymphoproliferative disease in immunocompromised cases. These are various EBV associated malignancies. Now coming to long-term complications of EBV infections, that is certain malignancies that which we have seen earlier, and we have also X-linked lymphoproliferative disease, nothing but Duncan's syndrome. This is a familial lymphoproliferative disorder usually associated with Epstein-Barr virus. In immunocompromised conditions, this lymphoma complicates Epstein-Barr infection. In immunocompromised, when patient is already having lymphoma, if patient is exposed to an Epstein-Barr virus infection, in those cases what happens is lymphoma complicates Epstein-Barr virus, and other complications which I have already seen can be manifested in those patients. Now coming to investigations. Various investigations that can be done for infectious mononucleosis include peripheral blood smear. In peripheral blood smear, usually patients will have atypical lymphocytes in the blood smear. And other pathognomic test, gold standard test for infectious mononucleosis is Paul-Bunel test. It is an Dr. Paul is one of the scientists who has actually first has done this test. So it is named after him as Paul-Bunel test. It is also called as monospot test. It is usually a test used to detect heterophil antibodies in acute illness as well as in the convalescent stage. This test is usually done on sheep agglutination, and this test will help us to find out the antibodies of infectious mononucleosis. And there are certain other specific EBV serology which will confirm the diagnosis, and IgM antibodies also can be seen against the viral capsid, antibodies against the genome, and antibodies against early Epstein-Barr virus antigen, and initial absence of antibodies against this Epstein-Barr virus nuclear antigen. These all features will denote acute infection. And seroconversion of anti-EBNA after 1 month of initial lesion is nothing but a confirmatory test for Epstein-Barr virus infection. Now coming to the management. This management is usually a symptomatic treatment. Treatment for pharyngitis has to be done with antimicrobial, especially the penicillin. Penicillin, if throat culture yields a beta hemolytic streptococcus, then penicillin is drug of choice. Usually in patients with IM, that is infectious mononucleosis, ampicillin and amoxicillin has to be avoided because ampicillin induced rashes are one of the most common complications in the case of infectious mononucleosis. However, short doses of corticosteroids can also be given in cases where there is severe pharyngeal edema, and if they suspect that this pharyngeal edema will block or cause obstruction of the airway, then short doses of prednisolone can be given 30 milligrams daily for 5 days. This will resolve the edema of the severe pharyngeal edema. And the topic for discussion now is MUMPS. MUMPS is also called as parotitis or parotiditis, and it is a systemic viral infection. As we all know, it is caused by paramyxovirus, and it is characterized by bilateral tender enlargement of parotid glands with a raised earlobe elevation, or with earlobe elevation, which is a pathognomic feature of MUMPS. Now, MUMPS are usually seen in children of age group 5 to 9 years, and even in young adults who has not taken a vaccination for MUMPS, that is nothing but MMR vaccination. And it is also spread by droplets, that is, it is a droplet infection, and the incubation period for MUMPS is usually about 19 days. Usually it has a broader range of about 15 to 24 days, and usually it is 19 days of incubation period. Even MUMPS has prodromal symptoms with fever and headache, which are the common prodromal symptoms associated with MUMPS, and in 10% of cases there will be complication of meningitis. And CSF analysis in these cases will reveal lymphocytic pleocytosis or neutrophils. Lymphocytic pleocytosis is nothing but abnormal increase in the lymphocytes in CSF. That is nothing but lymphocytic pleocytosis. Now, various complications can be seen, including encephalitis and transient hearing loss, abnormalities in ECG, that is nothing but electrocardiography, and also arthritis can be seen in these patients along with pancreatitis. These are various complications associated with MUMPS. In about 25% of post-pubertal males, epidermoorchitis is usually seen. However, though epidermoorchitis is a condition usually seen, rare in these patients with epidermoorchitis rarely undergo atrophy of the testicles. Euphoritis is less commonly seen in these cases. If MUMPS has occurred in the first trimester of pregnancy, abortion can also occur. Coming to diagnosis of MUMPS, it is usually clinical diagnosis. Clinically, there will be bilateral enlargement of the parotid glands, and the patients usually give history of prodromal symptoms such as fever, and earlobe elevation is a pathognomic feature. The earlobe will be elevated in these cases because of enlargement of parotid glands. And mostly MUMPS is a bilateral condition. If it starts as a unilateral condition, however, in 24 hours, it turns into bilateral enlargement. Serology reveals MUMPS specific IgG and IgM seroconversion. Virus culture can also be done in first week, especially in urine, saliva, CSF, and urine, saliva and CSF. CSF PCR can also be done, that is polymerase chain reaction of CSF also will help us in diagnosis of MUMPS. Coming to the management, MUMPS prevention is better than cure in any condition. It is also similar in case of MUMPS. Early vaccination in infancy, that is in childhood itself, with MMR vaccine is useful in case of it is a combined MMR, which is for MUMPS, measles and rubella. In this case, it will be helpful in case of preventing MUMPS. However, if it has occurred, then symptomatic treatment is advised. Symptomatic treatment, as it is a viral and it is self-limiting disorder, symptomatic treatment like analgesics, paracetamol, and to reduce the fever, antipyretics can be used helpful. More amount of rest, adequate fluids can be given to the patients with mumps. So symptomatic treatment will be helpful in case with mumps cases. Now coming to measles. Measles is also a condition which is also called as rubeola. It is again an exanthematic condition associated with fever, viral infection with exanthema. In these cases, measles are also spread through droplet infection and incubation period is about 6 to 19 days. Coming to the clinical features, usually mumps, measles is also associated with prodromal symptoms and it is seen 1 to 3 days prior to the rash that actually appears in upper respiratory system and also and conjunctiva, that is associated with conjunctivitis. There will be maculopapular rash, usually develops as a natural antibody and it spreads from face to extremities. So in the prodromal symptoms, what happens is the maculopapular rash is usually seen on the face first and then it spreads to lower extremities. This happens when the natural antibody within the natural antibody for this rubeola, for the measles is present, and then this maculopapular rash will spread from face to other body organs, that is nothing but lower extremities also. Normally, Copley spots is a pathognomic feature of measles. It is usually seen in the intraorally region. These are nothing but small white spots which are surrounded by erythema. This picture clearly shows small white spots which is surrounded by erythema seen on the buccal mucosa. It is pathognomic feature of measles, and these Copley spots appear much earlier than the rashes that are seen on the body. Hence, most of the times what happens is these Copley spots will not be identified or detected by the patient. As patients come for routine dental checkup or for any other oral health or any other oral health related problem, then dentist or oral physician will be the first person to observe these Copley spots. And generalized lymphadenopathy and diarrhea are other common symptoms associated with measles. In case of malnourished or immune compromised patients, there will be severe manifestations, especially giant cell pneumonitis and encephalitis can also be seen. Coming to complications. The complications are more common in case of older children and adults than in the younger age group, that is in infants. Normally complications include otitis media, we have transient hepatitis, bacterial pneumonia can be seen, and also clinical encephalitis. Rarely subacute sclerosing panencephalitis can occur. This occurs up to 7 years after the infection. So this is a rare complication and also a late complication. In TB, that is tuberculosis, what happens? There will be suppressed cell-mediated immunity, and this will further suppress the T cell mediated immunity, and hence it will cause exacerbation of the disease. And in severe pregnant women, if at all this measles occur, then it may cause congenital malformations to the fetus. Then in rare cases, there will be death due to bacterial superinfection. It is not just because of measles, but the bacterial superinfection that has been happening, and which include noma, cancrum oris or gangrenous stomatitis, and also measles encephalitis. These are the rare complications that occur, which are usually potentially fatal or which can lead to death. Now coming to diagnosis, usually this is also a clinical diagnosis where with the help of the maculopapular rashes, Copley spots and other clinical features, one can easily diagnose measles. However, detection of antibody, that is serum IgM, salivary IgM and their seroconversion will be helpful in diagnosis of measles. Now coming to the management. Normal immunoglobulin attenuates can be given within 6 days of exposure. In outbreaks, vaccination will be helpful. Vitamin A is known to improve the outcome of the uncomplicated disease. However, antibiotic therapy will also be helpful in case of any bacterial infections such as superadded infections other than measles. In those cases, antimicrobial therapy or antibiotic therapy will be useful. In all children from 12 to 15 months of age group, they have to receive measles vaccine. Measles vaccine has to be given in those younger age group children. This measles vaccine is nothing but a combined MMR vaccine, which is for mumps, measles and for rubella. It is nothing but a live attenuated vaccine, usually given in 12 to 15 months of age, and a second booster dose is given at the age of 4 years. Both the doses has to be taken to overcome any other disease in the future. Hence the booster dose is also very important. It is given usually at the age of 4 years. Thank you.